the most useful questions I find are the first three there: history of malignancy, recent weight loss, and night pain, are related to the red flag situations that I'm sure you're all well aware of. Malignancy, possible infection, possible fracture, catastrophic things like ruptured aortic aneurysms. The duration of symptoms is an important thing to elicit, and the response to treatment so far. We do talk about trying to differentiate back pain from leg pain. And although that sounds easy, in my experience, most people that you see will have some of both. They rarely tell you, I only have back pain or I only have leg pain. What I like to do is to sort out which one is predominant, particularly with leg pain, whether it's below the knee or not. Numbness or weakness is important to elicit from them, is at least the numbness or weakness that they perceive. Bladder dysfunction. What I'd like to point out is that if we are in an acute situation with someone with an acute episode of back pain and they're talking about bladder dysfunction and your concern is cauda equina syndrome, the bladder dysfunction in cauda equina syndrome is overflow incontinence. That patient will always have a full bladder. And so if you happen to be in an emergency department and have access to it, a bladder scan will with some certainty rule out a cauda equina syndrome or not. If the patient does not have a full bladder, they do not have cauda equina syndrome. Perineal sensation, people talk about saddle anesthesia, saddle paresthesia. I just want to be clear that when we do talk about saddle anesthesia and paresthesia, we're talking about the skin that would feel a saddle if you happen to be sitting on one. So the inner thigh and the perineum. I would caution you against getting into a discussion about sexual function in men because it's never as good as it should be, and it's not particularly helpful in this acute situation. So the mechanism of injury and the job description is important for WCB, but it's actually much less so for the diagnosis or management of people with back and leg pain. There is no recognized mechanism of injury for herniated lumbar discs, for instance. And so the mechanism of injury doesn't really help you a great deal in diagnosis or management. So the history and physical exam are really most useful to sort patients out into what I would like to call non-specific low back pain. For those of you who use the spine pathways, this would be type 1 and type 2 pain. The reason it's called non-specific low back pain is because it is almost impossible to say where that pain originates. The next big group is the patients with radiculopathy, with nerve root compression, either from herniated discs or from stenosis of the foramen or under the facet joints. And then there's a third big group, the other specific causes, the red flags that we talked about earlier, the malignancies, the occult infections, the fractures. So a few points now about the physical exam. The ability to achieve full lumbar spine extension is predictive of the good response to non-surgical treatment in patients who have radiculopathy. The inability to achieve full lumbar spine extension doesn't have any predictive value, and otherwise the range of motion of the lumbar spine has no predictive value. I see reports all the time from physiotherapists in particular, but many people who go into great length about the range of motion of the lumbar spine. I think it's reasonable to say that there's some restriction in flexion and extension or rotation, but it has no predictive value, and we no longer use range of motion of the spine when we're doing permanent functional impairment evaluations. It simply doesn't contribute to how well you actually function. So I would draw your attention, first of all, to what I call, or what is called sciatic scoliosis. And it is highly predictive of there being a lumbar nerve root compromise, but it doesn't tell you on which side, and it doesn't tell you about which level. And I would also point out to you, looking at this picture here of my son, that it is not, in fact, a scoliosis. It's a lateral shift, but it is easy to recognize once you've seen it. And as I've said before there, it is highly predictive of there being a lumbar nerve root compromise. So we'll move on to straight leg raising, a test that almost everybody does, and I think a lot of people don't do it particularly well. A few things you need to know. The nerve root does move during a straight leg raising test. It moves about 7 to 12 millimeters inside the root canal. That movement doesn't start until about 30 degrees of flexion, and it stops at 60 degrees of flexion. A positive straight leg raising test is not back pain. It is leg pain below the knee, usually replicating the pain that the patient is complaining of. A straight leg raising test that is positive above 60 degrees doesn't really mean anything, and a straight leg raising test that is positive below 30 degrees, again, has no predictive value. If the straight leg raising test is negative, that is very accurate in ruling out significant nerve root compression. In other words, it's a test of high specificity. If the straight leg raising test is positive, it's less predictive of nerve root compression. And otherwise, you can have a positive straight leg raising test, which is a false positive. So straight leg raising test of less than 30 degrees is highly suspect and probably doesn't represent radiculopathy. The situation where I see this most often when the patient actually does have radiculopathy is if they have had a straight leg raising test done multiple times before, and they know that this pain is coming and they don't want you to cause them the pain. They will sometimes restrict straight leg raising. But if you can get them to relax, you should be able to get straight leg raising to at least 30 degrees with no pain, because the nerve root hasn't moved until that point. The other thing I would point out to you is that pain caused by straight leg raising within the 30 degrees to 60 degrees should be relieved by knee flexion. And if it's not, it very likely does not represent radiculopathy. And so straight leg raising pain not relieved by knee flexion is highly suspect. Crossed positive straight leg raising. In other words, if the patient has left leg pain and the right-sided straight leg raising test produces left leg pain, this is a highly significant finding. There are multiple studies. It has a strong predictive value for nerve root compression at the L4-5 or L5-S1 levels, and it also predicts poor outcome for non-surgical treatment if it's present still after 3 months of symptoms. Bragger's test, which is dorsiflexing the ankle at the end of a straight leg raising test, has limited literature, and it really doesn't add any predictive value to the test itself. Most people do it, I do it, but the truth is there is limited literature that suggests that it adds anything to a straight leg raising test. Bowstring sign, again, very limited literature. Very similar to a straight leg raising test. I like to do this myself. I've done it for years. It requires that the patient have release or relief of pain when the knee is flexed. And then I'll demonstrate it to you here in a little bit. But if the knee is flexed and then you put pressure in the popliteal fossa, you should be able to recreate the leg pain by bowstringing the sciatic nerve across the popliteal fossa. Slump test, often reported, is simply a sitting straight leg raising with the cervical, thoracic, and lumbar spines all flexed. Again, limited literature, and it's in the same category as a straight leg raising test and a bowstring sign. The femoral stretch test is the best screening test for upper lumbar radiculopathy, L2 to L4. You don't see it very often because 80% of lumbar nerve root compromise is lower than that, between L4 and S1. And I'll demonstrate that in a few minutes here. Waddell's tests. Dr. Waddell is a Scottish orthopedic surgeon who spent a year in the WCB facility in Toronto in 1980. And he was concerned about the number of patients who appeared to have what are called failed back syndrome. In other words, they had surgical treatment and were no better or usually worse. And he suggested that you could identify these people before they had surgery by doing a set of tests, which I will go into some detail here about. Now, these tests don't prove that the patient is malingering, but they identify a need for further psychological testing. And if they're positive, they usually eliminate surgery. It would be difficult to find a surgeon who would be keen to carry out surgery on a patient who had positive Waddell's test, because the prediction is that they would not do well. Hold on a second, let me go back. Yeah, I missed a slide here. So the Waddell's tests are superficial non-atomic tenderness. In other words, superficial tenderness to light palpation over the spine, overreaction to any of the tests, pain on what are called simulated maneuvers, axial compression. If you put some pressure on a patient's head while he's standing, that should not cause any pain. If you clamp the arms by the patient's side and turn the shoulders and hips together, it looks like the lumbar spine is turning, but it's actually not. And that shouldn't cause any pain either. A significant discrepancy in physical testing, like differences between sitting and supine straight leg raising or sitting and supine hip and knee flexion, should cause you some concern. And non-physiologic findings such as non-dermatomal sensory loss. In other words, a patient who has numbness in his whole leg is, again, a concern for a positive Waddell's test. And give-way weakness, weakness that suddenly occurs as you ask the patient to use a muscle. So if there are 3 or more of these positive tests, then that's indicative of physical findings without an anatomic cause. As I said before, it doesn't prove that the patient is malingering. They might be, but this is not what the tests are about. It simply identifies a need for further psychological testing. And as I said before, it usually eliminates surgery as a treatment option. One other test in that same realm is Hoover's sign, which is based on a crossed extensor reflex. It's highly specific and it demonstrates what's called functional weakness. Now, Hoover's test, I did have a slide on how to do Hoover's test, but I think it's missing from today's talk and I'm not sure why. However, if the patient is lying on a table and you ask them to lift up their right leg, this crossed extensor reflex causes them to push the left leg into the bed. So if you have your hand under the left heel and you ask them to lift the right leg, you should feel pressure on your left hand. If you do not, that is a positive Hoover sign. And as I said, a highly specific test. If there's no pressure on the left heel when you're asking him to lift the right leg and the right leg doesn't move, then this is functional weakness and is treated the same way as a positive Waddell's tests. So the likelihood of radiculopathy findings from the physical exam are listed here. Cross-positive straight leg raising, highly significant. Straight leg raising between 30 and 60 degrees, very significant, given that the pain should be relieved when the knee is flexed. A positive femoral stretch test, significant. Radicular pain below the knee, significant. Sciatic scoliosis, very significant finding. Muscle weakness that correlates with the finding on an MRI of nerve root compression, and reflex change at either L5 or S1, not L5, L4 or S1, correlating with an MRI also is significant, but less so than the femoral stretch or cross-positive straight leg raising. L5 is usually not associated with any reflex. So this slide is simply a list of all the references that I used to arrive at the points I just made and the physical exam and the importance of the physical exam. So the predictive value of physical findings relating to nerve root compression are only really related to direct nerve root compression. These physical findings don't identify things like disc bulge, disc desiccation, loss of disc height, end plate sclerosis, facet joint degeneration. These things are not identified on the physical exam. Sorry. Annular tears, annular tears, you will still see that term reported on MRIs. It shouldn't be. They should now be called annular fissures. This was a recommendation from the American neuroradiologists over 10 years ago. The reason being that the term annular tear was assumed to be a traumatic finding, but it's not. It's a degenerative finding, and so they are now officially called annular fissures. But I do see MRIs still being reported today, more than 10 years after that guideline was issued, talking about annular tears. They are not traumatic, they are degenerative. So the spine exam that I do doesn't actually take very long. I start by walking the patient, heel walk, which is testing L5, toe walk, testing S1, single leg squat, testing L3 and L4. And now this is a test for muscle spasm. There's no name to this test. I've been doing it for years, and it was taught to me by a fellow who had just come back from a time at Rancho Los Amigos, which is a rehab hospital in California. It's based on the fact that when you move from side to side, you lower your spine down, you do not pull it down. And so the muscle in the concavity, which in this picture here is on the left, relaxes. And that relaxation is beyond cortical control. No matter how much the patient wants you to think they have muscle spasm, that muscle will relax if in fact they don't have muscle spasm. So this is what it looks like. So relaxation occurs in the concavity. And as I said, I don't actually have a name for that test, but I find it to be very helpful. I do my muscle testing with the patient seated at the end of a table like that. It allows both muscle testing, it allows for sitting straight leg raising, and I'm going to show you a tripod sign in a second, which is what happens if the patient does in fact have sciatica and you do a sitting straight leg raising. They will lean back and support themselves with their arms. Again, it doesn't take very long to test all the muscles in the lower extremity. When you're testing quadriceps, you're also doing a sitting straight leg raising, which is clearly there 90 degrees. If the patient does have sciatica, they will lean back and put themselves into that tripod position. Again, a very reliable sign of positive straight leg raising in the sitting position. The supine straight leg raising, we'll just demonstrate here. So that would be a negative test, which is highly reliable in excluding radiculopathy. There's a positive test, pain relieved by knee flexion. This is how I do a bowstring sign. Put the foot on my shoulder, push on the hamstrings as a test, and then push on the popliteal fossa, which causes pain. That would be a positive bowstring sign. Femoral stretch test, which is highly reliable for the L3 and L4 nerve roots, is done prone. That would be a negative femoral stretch test. Flexion, abduction, external rotation, so-called Faber test, is a good way to eliminate the hip and sacroiliac joint as a potential source of pain. If the patient is actually able to do a Faber test, that requires full range of motion of the hip. If they do have pain anteriorly, that usually represents hip pain. If the pain is posterior, that is suggestive of sacroiliac joint pain. If they cannot get into that position, then I think you're obligated to do a more detailed examination of the hip and find out if the hip itself is the source of the pain. In other words, if there's any limitation of abduction, external rotation or internal rotation. But if they can do this test, then they have essentially full range of motion of the hip. So that's the end of what I was going to say about physical exam and its importance and how to identify radiculopathy as opposed to non-specific back pain. I'm going to talk a little bit now about what happens in the spine as we age. Two parallel, independent, inevitable processes. One, reduction of bone density, and two, the development of degenerative changes. These changes begin in the second decade of life with decreased production of extracellular matrix, loss of water and proteoglycan, decreased disc height, radial tears, which are now called fissures in the annulus, beginning in the third decade of life. Up to that point, there's no nerve endings in the nucleus, so you can't actually feel your nucleus. When you do start to get degenerative changes, you do get new blood vessels entering the nucleus, and there's now proof that they have pain-sensitive nerve endings, so you can get discogenic pain, although it is very difficult to identify, and it's simply one of the components of non-specific low back pain. The reason we use that term non-specific low back pain is because it doesn't really matter what element of the spine is causing the discomfort. If the discomfort is not radiculopathy, the treatment, at least in the first 3 months, is the same for all of them. It is a promotion of activity, avoidance of bed rest, avoidance of passive treatments, and avoidance of narcotics, and the reassurance that most of these people will improve within 6 to 12 weeks. Facet joint degeneration starts in the 40s. It's usually secondary to disc degeneration. If you think of the disc and the two facet joints as a unit, if you start to have loss of disc height, then something has to happen in the facet joints to match that. So you get loss of disc height, you then get facet joint instability. With increased load on the facets, you get osteoarthritis of the facet joints. You start to see osteophytes and joint swelling. That produces foraminal stenosis and also more central spinal stenosis. That can result in instability and lead to degenerative spondylolisthesis. So this would be the degenerative cascade that occurs as we age. It is inevitable, but hopefully it is often smooth, it's delayed, it's relatively pain-free in spite of significant progressive radiological evidence of degeneration. And with time, the lumbar lordosis decreases, the thoracic kyphosis increases, particularly if you get osteoporotic compression fractures. And this slide represents the possible outcomes. Hopefully, we will all have stable spine with reduced range of motion as the end point. Unfortunately, you can have an unstable spine, which will lead to spinal stenosis, it will lead to degenerative spondylolisthesis, and it will lead to degenerative scoliosis and kyphosis.